House Appropriations Subcommittee on Medicaid and Behavioral Health will come to order. Clerk, will you please take the roll?
Chair Van Workum.
Here.
Vice Chair Green.
Present.
Representative Roth.
Here.
Representative Kuhn.
Here.
Representative Robinson. Vice Chair Rogers.
Here.
Representative Glanville.
Present.
Mr. Chair, you have a quorum.
Thank you, Mr. Clerk. Representative Kuhn moves the minutes be approved for the March 3rd meeting. Seeing no objections, the minutes are approved. Thank you, colleagues, for being here today. Thank you for the presenters that are going to be here. We're talking about an important issue as it relates to the Medicaid and behavioral health budget regarding CCBHCs. One of the things that I've noticed over the years, this program kind of started in 2021. And in 2021, 2022, the general fund budget for CCBHCs was $4.5 million. And the last one was $165,478,800, which also included $750,583,900 for the feds. This is one that there is a current demonstration program going on where the feds take 75% of the cost. But in October 1st, 2027, we expect that that will end and will go to the traditional Medicaid rate of 65%. So this has become a large portion of the behavioral health budget, and I think something that the committee is interested in hearing how it's working and what the process is moving forward. So with that, I'm going to ask, and we've got 3 presentations today. We have one from DHHS, one from Community Mental Health, as well as one from Easter Seals. And with that, I'm going to ask Megan Groen, the Chief Deputy Director of Health Services for the Department of Health and Human Services, to come on up. Thank you for being here.
Thank you so much, Mr. Chair and committee, for having me here today. I am excited to talk about what a great program CCBHC is, been in the Medicaid space. Thank you for kind of talking about a little bit why we're here today. We'll touch on a little bit where we are in the demonstration, what that looks like for ongoing, and kind of what sustainability and what the department's working on in that space. But really important things that you brought up there. Wanted to talk a little bit about the behavioral health landscape in Michigan and why having a program like CCBHC matters right now. We are seeing a rising demand for mental health and substance use disorder services across all ages in the state and nationally. After several years of steady rates, in 2022, rates of serious mental illness, suicidal thoughts, and youth depression have increased significantly. Over the last decade, the prevalence of substance use disorder has more than doubled. And Michigan is pretty consistent with the national average, around 23%, slightly over for adults with serious mental illness. So something that we're seeing in Michigan and across the country. The Medicaid population in particular experiences disproportionately high rates of mental health conditions, substance use disorder, or both. So as a result, this population is more likely to experience poor health outcomes and have frequent visits to the emergency department and hospitalizations. Nearly 40% of non-elderly adults on Medicaid have a mental health or substance use disorder. So a little bit what we're seeing is workforce shortages, wait times across the state. Rural communities are facing kind of that steepest access gap and the fewest providers. And so that's something that, despite these huge strides, crisis response, also the capacity remains uneven across the state. So our community mental health associations do a great job providing an array of crisis services. Individuals in crisis are a priority population. But CCBHC adds a little something to it. The 24/7 mobile crisis requirement for CCBHCs is unique to this model, and it actually expands the state's capacity to serve individuals in crisis significantly. So that's kind of where the CCBHCs are relevant. Michigan has, as you mentioned, invested more recently in this program. Kind of those personalized and integrated care is designed to reduce the visits to the emergency department, improve behavioral and physical health outcomes, and address health-related social needs such as housing, food, transportations, doing all of these things designed to kind of reduce the fragmentation in the system and improve accountability. We get asked a lot, what is a CCBHC? We have a lot of acronyms in this space. So it is a specially designated clinic that provides a comprehensive range of mental health and substance use disorder services. It's a no wrong door approach. They will serve you no matter who you are when you show up. There's the 24/7 crisis response, and it is an integrated mental health, substance use disorder, and primary care screening. We often see that people don't just have one thing that they want to deal with their healthcare. They have a lot of things going on all at the same time, and it is really important for our providers to be able to meet those needs. Wanted to talk a little bit about the CCBHC background and timeline, how we got here today. I think the chair gave us a little bit of an overview already, but just as a refresh, CCBHCs are a federal demonstration project. Michigan has leveraged additional access to mental health services through the program and brought more federal dollars into Michigan's behavioral health system. So over the last few budgets, the legislature and the executive have appropriated both the funds required to bring down the enhanced federal funding to enter the demonstration, and then offering 2 expansions for eligible providers who meet certification requirements. So that's as we've seen the budget grow in this program, a result of those expansions that were worked out through the state budget process in 2023 and 2024. In terms of where are CCBHCs today, there are more than 500 CCBHCs in the country. They're operating in 46 states, and I believe Puerto Rico and DC as well. We have 35 in Michigan's demonstration project. They are serving 82% of Michiganders across rural, suburban, and urban communities. The networks include both our community mental health associations as well as nonprofit community-based provider organizations. I think you're going to hear from both of those representatives from both of those entities today. So that growing reach of these CCBHCs are expanding service delivery footprints beyond the clinic walls. So they're partnering with community-based organizations, partnering with schools, partnering with law enforcement, hospitals, to really make sure that they have that full reach, not just in the clinic themselves, but in the community. Nearly 150,000 individuals in Michigan were served by CCBHC last year. That is a 12% increase from 2024. One key component of CCBHC is that it broke down some of the geographic boundaries of Michigan's behavioral health system. So you will see more than 46,000 individuals receive CCBHC services out of their county of residence. It's an important number for us, but I don't think it makes a lot of sense without context and thinking about the way our behavioral health system works today. And that is largely driven by where you live, what county you're in, what that looks like. And so what CCBHCs are able to do is serve people regardless of their county of residence. So if you live in Oakland County and you work in Wayne County, you might be able to get services in Wayne County. If your college student is from Ontonagon, but they're going to Michigan State, they're going to be able to get services in East Lansing. So it's not broken down by that geographic piece that I think some of our community mental health associations have struggled with in the past because they had to kind of go by that county of residence. So we do actually see a lot of individuals receiving those services outside of their county of residence. Wanted to talk a little bit about CCBHC and the crisis continuum and what that looks like. When we were talking about expanding CCBHCs in the state of Michigan, I'm not sure I fully understood what a role they would play in the crisis continuum and for individuals experiencing crisis and how they kind of fit into that system. So all of our CCBHCs, so 35 of them, have established behavioral health urgent cares with expanded crisis walk-in services to serve acute needs. So just as you would go to an urgent care for your physical health needs, you can go to a CCBHC for your behavioral health needs. And that's very important. 82% of Michiganders now live in a county with 24/7 mobile crisis. When we treat people in the community, like a CCBHC does with all of their community partners, people are closer to their family, they're closer to their support network, they are more likely to stabilize and get continued treatment, they're less likely to need expensive inpatient treatment or have law enforcement involvement. And those inpatient beds are freed up for people who really need them. So you see on here, we have 24/7 mobile crisis listed. We also have crisis stabilization units, and these are short-term, up to 72 hours clinical interventions, thanks to the support of the legislature, who passed some legislation a few years ago, and partnership with some of our community mental health programs. CSUs have been open for about a year and a half in Kent and Wayne County. They're serving over 5,000 people last year. Genesee Health System is also planning to open in the spring. CSUs are really looking to avoid that inpatient stay and preserving inpatient beds for individuals who truly need them. In the most recent quarter, we had 1,749 individuals who came to a CSU for help. Only 173 of them were admitted to psychiatric inpatient. That's less than 10% of the people who came into a CSU. And by the way, a CSU is an inpatient level of care, right? So they're able to be stabilized in that 72 hours, working with our CCBHCs, our community mental health partners, to get folks treatment in the community so that they don't have to go to inpatient care. These kind of 94% of the individuals who came to a CSU also did not require an emergency department, which is very important. These service delivery models are working together. They're avoiding costly inpatient psychiatric care, emergency room visits, and unnecessary jail stays. And so these recent investments that the legislature has made, both in CSUs and CCBHCs, and other step up, step down transitional services, have really relieved some of the pressure on our hospital emergency departments, and made sure that we have places for people to go. Talk about what's working, CCBHC impact in Michigan. I've testified on CCBHCs a couple of times to the legislature, and I'm very excited that now, being several years into the demonstration, we have a lot of data to really support what they're doing, what it looks like, what the impact is. And people are really asking us a lot of questions like, are people actually getting served faster, right? Is it working? We are seeing a 63% decrease in time to services since demonstration year one. That's incredible. In just a few short years, we have really made it, and these great community partners that we have made it so people are getting services fast. Telehealth is a major rural access lever. CCBHCs are required to offer telehealth. Telehealth has helped broaden the reach of CCBHCs as they have relationships with schools, community partners. Many of our CCBHC locations are also community mental health agencies. They previously only served those with severe mental illness. That's how they're funded. Through CCBHC, access has been expanded to those with mild to moderate behavioral health needs. So I think we have this here as the 13% of Medicaid daily visits were served to beneficiaries with mild to moderate behavioral health needs. I think this is an important statistic. I think that people don't know what it means unless they know some of the background of our behavioral health system, right? And so in Michigan, you are, it's a bifurcated system, so you're served with your Medicaid health plan if you have a mild to moderate condition. You're served by the PHP-CMH system if you have severe mental illness. So what if I don't know what I have, right? I don't want to go somewhere and be told, oh, you're not severe enough, you need to be over on this side, go to this provider. I don't want to be told I am too severe and I need to be somewhere else. I want to be served right there. And I think that's something that we had heard from a lot of our partners for years and years as people are coming there. They're saying, I need help now. But they don't want to send them to somebody else. They want to be able to serve those needs there. And so it has really been a great way, I think, although I'll let them speak for themselves, for a lot of our community mental health partners to be able to expand access and making sure that they're serving people when and where they need them. A little bit more on crisis. As a result of the demonstration, 82% of Michiganders now live in a county with 24/7 mobile crisis. The impact of this cannot be understated. As we're seeing the growth of crisis services, this growth, we're seeing two different things at the same time. It doesn't necessarily mean that people are experiencing more crises. It means that individuals who are already in crisis are now actually able to access that appropriate community-based care. We are also seeing rising treatment utilization across the country. So nationally, mental health treatment increased from around 19% in 2019 to 24% in 2023. Young adults, especially, utilization rose 45%. So you're seeing both of those things happen at the same time. More people accessing treatment, as well as making sure that as people need treatment, it's available. So that is something that, before CCBHC expansion, many of those same crises were either unmanaged, they were routed through emergency departments or law enforcement because there was no timely, dedicated crisis response available. Wanted to talk a little bit about quality, which, I'm not sure everyone gets as excited about quality data as we do at MDHHS, but it's something that as we're just getting data back from our most recent outside evaluation, so other people evaluating the program, seeing how it's going, what we can do better, and it's very exciting. It can be really challenging for providers to look at serving new populations, to look at different financing mechanisms, to be asked to change their care delivery model. But in just a few years, providers have done a truly amazing job with this model. I'm really in awe of these performance metrics and quality metrics. CCBHCs are consistently outperforming statewide averages on many of the most important behavioral health quality measures that we see. So we have higher follow-up rates after emergency room visit and hospitalization for mental health and substance use disorder. That means that we're stopping the cycle of people coming in and out of hospitals, that we're making sure that they're getting that treatment and following up. We're seeing better chronic disease monitoring, including diabetes screening for individuals with serious mental illness. And we're seeing earlier engagement in substance use disorder treatment, improving long-term recovery outcomes. And that's significantly reducing that time to services, again, a 63% decrease since demonstration year one. So we're seeing faster access, stronger care coordination, and better outcomes. We were a few years behind some of the other states in the demonstration, so we had a little bit of an idea of what to expect. What at least I didn't understand was how quickly we would be able to get there. So we can look at the data and see a significant decrease in emergency department use among individuals served by CCBHCs. That means this is a real diversion from those high-cost, high-acuity settings. So that means we have avoided hospital stays and emergency departments, jails, all of the things. So a nearly 500% increase in outpatient substance use disorder services since fiscal year 18. So that's expanding access of evidence-based care, opioid use disorder, stimulant use disorder. People who need substance use treatment need it. They need help right away. And you can walk in and get treatment right there, not in a week, not in a month. In a month, we don't know if you're going to show up, but right then and there. So that is an incredible statistic. And we also wanted to highlight the veterans services. It's a required service in CCBHCs. From 2022 to 2024, we have seen the CCBHC used by veterans nearly double. Doesn't mean other people don't want to see veterans. This means that we're actually talking with specific individuals who are trained to talk to veterans, and something that was really a gap that people found in our system is required service. We're also seeing a lot about increased staffing levels, improved retention, kind of supported by that stable financing that they get. I go on a lot of visits. I talk to a lot of providers. It's really important to me to see what's happening in the community, to really hear from providers about, and I always say, what do you need? What can we do for you? What problems are you experiencing? It doesn't matter if I'm in the UP, if I'm in Grand Rapids, if I'm in Detroit, and I'm in our rural communities, every single person says staffing. And so knowing that this is an evidence-based way to support our providers with their staffing models is something that's very important. Wanted to talk a little bit about what comes next. The chairman was, brought up. We are in a demonstration now. In that short-term horizon, we are in year 5 of 6 of the federal demonstration. So that does conclude at the end of the fiscal year 27 budget. So kind of what we need to talk about and what the state responsibilities are. We have seen a number of states pursue CCBHC as a permanent Medicaid benefit, so it can be added as a permanent Medicaid benefit and become a part of the program. As the chairman mentioned, that would bring us from a 75% federal match to a 65%. We're looking at strengthening those financial modeling, kind of the geographic planning. There was a spatial analysis study required in the fiscal year 25 budget. So we are looking at that and kind of looking as the future of the program, where on a geography basis, what that looks like, and kind of continuing that operational readiness and workforce stabilization efforts. We have joined into a transformation project that is funded by the Balmer Group, so at no cost to the state, that is being run through the National Council. This is a 3-year initiative launched in 2025. We are joined with a couple other states, Kansas and Illinois, and it is providing us financial support in kind of in-kind technical assistance, workforce support with a lot of consultants that are working with states across the country, looking at how to structure reimbursement and financing to really maximize that service delivery while minimizing the cost to the state as we kind of look at that change in reimbursement rates from the federal government. So they are working with us on some pretty big areas, kind of with staffing resources, advancing statewide vision for CCBHC, looking at scaling up services, workforce investments, and also importantly, intensive technical assistance for our clinics. Sometimes people want that through the state. Sometimes they want to work with each other. Sometimes they want to hear what's happening across the country. And this is an ability for us to support that work and not necessarily be the driver of everything, but really share what's happening around the country. So to wrap us up a little bit, just wanted to talk about kind of as we look at the huge investments and thank the legislature for making them in this program, why it's important that we continue those investments is that looking at Michigan, we've talked a little bit about statistics in the state of Michigan, how great those quality measures are. Also wanted to talk a little bit about across the nation. CCBHCs are widely acknowledged as kind of an integrated and financially sustainable care delivery model. According to national HHS, CCBHCs have accounted for a 74% reduction in mental health hospitalizations, a 68% decrease in emergency room visits, and a 33% decrease in homelessness. So the big things that has done is really expand that access beyond Medicaid eligibility, so people aren't sitting there on right when somebody's walking in worried about what their Medicaid coverage is and things like that. So reaching people that might fall through those gaps, building that crisis in substance use disorder response capacity, so that reimbursement model is really supporting team-based care, and improving stability in the behavioral health workforce, supporting competitive wages, retention, that workforce, I can't emphasize it enough, and really strengthening those outcomes and reducing those downstream costs through earlier coordinated interventions. So when we're working with our community partners, we're working with our jails, we're working with law enforcement, we're working with our schools, we're able to make sure that people are having that sustained treatment that they need in the community to avoid those more costly inpatient stays, hospital use, those pieces. So with that, I'm happy to take questions if anyone has them.
Thank you for the presentation. Representative Green.
Thank you, Madam Chair, and thank you, Director. Appreciate you being here. As we look at, you'd use the phrase a sustainable model, and we're looking at, on the Medicaid side, the mild to moderate. Excuse me. How do we juxtapose that phrase, the sustainable model, with what is appearing as our complete increase in our costs every year as compared to what Medicaid is paying? So Medicaid is paying for their services, let's say in a fee-for-service or in a managed care, yet we're supplementing to the tune of, what was the number, I forget what it was said at the beginning.
This fiscal year, 165.4 million.
So 165. So it seems like we're just going to keep supplementing behind the scenes, and so at what point does that become unsustainable? Or some would say that it already is. But can you talk about that model of the financing, and then how we can turn it into a model where it doesn't completely cost the state on top of our Medicaid rates as well?
Yeah, so I think it's a really important question and a really important thing for us to kind of look through as we're kind of talking about what this looks like as, a permanent program and Medicaid as well. What I will say in terms of the financing, the mild to moderate, in terms of I think what you're getting at here is now that we have a bifurcated system, right? So through our Medicaid health plans and that managed care, they are serving the mild to moderate population. A lot of what we're doing with CCBHC is, either substance use disorder or serious mental illness. But there is that 13% that's mild to moderate. And so those individuals, in terms of their behavioral health needs, would not have been included in the health plan rates at all for those services. Those are through the PIHP and CMH system. And so that's kind of a different line in the budget. So as we're looking at that, you need to take those two lines together, really looking at those specialty behavioral health. In terms of the mild to moderate population that our CCBHCs are serving, I think it's a fantastic question. Those should be accounted for as we're working with our actuaries in the rates so that those are not being paid to the Medicaid health plans in order for them because they're being served over here in this system. And that's something our actuaries work very hard to make sure it's required to make sure that we're kind of serving those and putting those separately and bucketing them. So if we were to say not have CCBHC services, I think what you would see is have those transfer into another area because they'd be served in a different location. We still, as the state, would be required to provide those services. They would just be in a different provider base and a different network paid through the Medicaid health plans. And so you would see that piece. You also have you're looking at both of those pieces together in those systems. This is good for access for people because it kind of brings those pieces together. And so, as we're looking at the CCBHC line, which was taken out, I think, when we look at the budget of kind of our specialty pieces so that we could really monitor so that you guys could take a look at that line, see how it was growing, what that looked like. So I think we can kind of look at that in coordination with kind of our specialty behavioral health line and how we're paying those. We can certainly get you more information from our actuaries about what that looks like and how we do build those rates.
So what you're saying, I'm looking at the who's being served, fiscal year 26, 138,500 Medicaid, 23,500 non-Medicaid. So we're looking at, just for round numbers, 150,000 people being served, and of that 150,000, 25,000 are non-Medicaid. Mm-hmm. So about 16% are non-Medicaid. So you're saying it's actually cheaper for us to build $150 million into our budget than to increase what we're giving to our managed care and have our managed care when they walk in, just like they would with any insurance. You're saying the managed care systems would increase their cost by more than $150 million?
Well, not necessarily. So if I gave you that, so those people would need to be served somewhere. And so we would put the money then in the managed care rates as opposed to here. I think you brought up a couple interesting points there for the non-Medicaid. And so that's something that previously, I think our community mental health partners can probably speak a little bit better than I can to some of this, but they also have to serve people that are coming there. They do some of that through general fund. And what CCBHC has allowed us to do is have them use Medicaid dollars, so allow that federal match to come down as opposed to using just general fund dollars. And so those would be responsibilities for the CMH. In terms of the Medicaid health plans, we could look at different ways to structure the program. That's certainly something we're doing through the Ballmer Foundation's grants, and that we're looking at how other states do that. You can certainly pay, a CCBHC can bill in different areas. And so we could kind of look at what that model looks like. If you want them to be billing health plans, if you want them to be billing the state directly, and what that looks like. But that's certainly something that we can look at in the future. And I think is the right time to have that conversation as we look at a permanent model. If you want some of that built into managed care, if you want it fee for service through the state. And certainly something that we've worked on with other states. Michigan, Medicaid is supposed to be the payer of last resort, right? So we have a very strong third-party liability team in the Medicaid program. They actually do $6.8 billion of cost avoidance every year because if somebody has Blue Cross insurance, they have, whatever, that's who should be paying that bill. Medicaid is last. And so it's something that, as we look into the future, we can certainly look at what billing looks like, what structure looks like, and making sure that we're able to leverage all of those resources for our CCBHCs to bill a diverse group of payers.
Representative Rogers.
Thank you, Chair. I do want to thank my colleague, Rep. Green, and former Rep. Braybeck for working on these policies. I think we had bills on this last term that were referred from my Health Policy Committee to the Behavioral Health Subcommittee that we had, and then passed them out to the floor, so it was a good bipartisan package. I appreciate the timeline, or Megan kind of outlining what our responsibility is in 2027. Are there other steps being taken, or can you kind of outline on a macro level what the department is thinking for ideas as we approach that rather quickly? And then my other question, which you may need to get back to us on, is I'm a huge fan of the crisis stabilization piece. I think it has a major ROI and cost savings. I'm curious if you can get us any kind of numbers. I'm not sure what that represents of the whole CCBHC bucket, how much is for the crisis stabilization. And again, if you don't have that at your fingertips, you could totally follow up.
Yeah, so I think those are some great questions in there. I'm going to try to hit all of them, but if I don't, please feel free to call me out on it. So I'm going to talk about crisis first. Obviously, there's a reason why I had multiple slides on crisis. I think CCBHCs are a huge place. We always talk about in kind of the SAMHSA model, right, of somewhere to call, somewhere to go. And so CSUs are really that somewhere to go, right? And so I think it's been important. It's really, our numbers have really proven with jail diversion, with inpatient diversion, those types of pieces. I think CCBHCs are really important because they're working together on that. So in terms of crisis services, a CCBHC can only hold somebody for up to 24 hours, right? So you're not having those overnight stays that a CSU would. And so the models are different. And so we can kind of get you, I don't know off the top of my head, but we can get you a breakdown of kind of how those rates are built and what that looks like. It's a little bit different than other areas of the budget, you will see, because providers kind of help build those PPS rates depending on where their geography is, the services, all those types of components. But we can certainly walk through that at a greater detail, because crisis is a huge piece there, right? So you have that 24/7 mobile crisis. You also have the people that are walking in your door. If they need to have an overnight stay, they do need to go to either a CSU or some type of other inpatient level of care. I don't know the stat off the top of my head, but I do know that we are avoiding a lot of those by having people be able to be stabilized in a CSU. A lot can be done in 24 hours, but they cannot bill for anything over 24 hours or having that piece. And so when you look at CSUs, it is a model that not everyone's going to be able to do that. Not everyone's going to be able to have a 72-hour overnight stay, do the food associated with that. Traditionally, Medicaid can't pay for a number of those pieces, right? And so, again, it's just a different space, so we need to keep those kind of separate in terms of our financial and our billing. But it's something that, if somebody can be, we're going to have a lot more areas of the state that can do a behavioral health urgent care, right? Then we are going to be able to do a full-blown CSU. And I think that's important as you're looking at what we can really ask our providers to do and what they're going to be able to do in those communities. But knowing that there's such an interest in kind of cost avoidance and kind of financial structures, that's something that we're definitely looking at in that national model, and kind of why we wanted to look at that on a consulting basis of like what other people are doing to see how they're making it sustainable. A lot of states have already made this a permanent Medicaid benefit and have gone down that road. I will say when they did that, they lost their enhanced match. So I think the way Michigan was doing it is a smart way to look, right? Making sure that we're drawing down that federal enhanced match for as long as we can, and really giving us some time to research those other models and what that looks like so that we can make the program as sustainable as possible for the future.
Thank you, Representative Roth.
Thank you, Mr. Chair. Thank you for being here.
Yes.
Am I sensing that the department wants to pursue this in a larger capacity throughout the state?
Well, certainly, we've done 2 large expansions of CCBHC. We were asked to take a pause in the budget last year on any expansions, which we continue to work with providers. They ask us questions about expansion and like how to be ready for those services. When we first expanded, what we saw is people couldn't meet the criteria. There are some places in the state that want to be a CCBHC, and there's some that don't, and that's okay too. But certainly something that there continues to be larger interest from people who are not currently CCBHCs that really feel like they could meet that criteria now. I don't have any current plans of expansion unless you all tell me I do, and it lives in a budget.
Yeah. How many of the 35 are north of Clare?
Yeah, that's a great question. We do not have a lot up north, and that's something that in the last budget we were also asked to kind of talk to some folks up north and see if there was interest in expansion. I will say there is. I don't think there was back in 2020 when we started. It's a hard model to kind of wrap your head around, and especially that 24/7 crisis can be challenging. There's some very strict federal criteria in order for me to draw down that money. I have actually had a lot of conversations with SAMHSA and CMS and others about, how Northern Michigan looks a little bit different. And if you really want this to be a model that can be used, we need to take a look at some of those things. I will say there's some traction there. We also have some providers up north that I do believe are interested.
Yeah, I'm just concerned the consistency of the money finding its way throughout the state.
Yeah.
Is always a concern in northern
I think that's a very valid concern. I will say we do have a lot of behavioral health homes, which are also that integrated model, as well as opioid use disorder. Well, now they're substance use disorder health homes. The health home model has been very popular up north. I didn't talk about it today just because we were kind of focused on CCBHCs, but we do have a lot of partnership in those kind of newer, more integrated models up north, and people who really like that piece. So that might be something that we could dig into. I don't want to tell providers what service delivery model is right for them, what financing model is right for them. I want to make sure that they have options that they can utilize so that they can best serve their communities. And so, there might be things that we can look at in that space as well.
Thank you.
Thank you, and we do have two more presentations, so I guess I'll ask just a couple quick questions. Kind of along the lines of Representative Ross here. We have 7 CCBHCs in Wayne County area, I believe, and then a part of the rural health transformation, there's a request for 4 in rural areas, I guess. And then you mentioned, I believe, in your presentation that you're working on one in Genesee, or that's been approved.
That's a crisis stabilization unit. So
Okay.
lives
All
in a
right.
different area of the budget. That's a different piece. You've already appropriated that money.
All right, thank you. I guess kind of what is the criteria or what is the process to establish a CCBHC? And I know there were intentions of opening another in the Wayne County area. Why weren't the ones in the rural areas considered, or where are they along in that process?
Yeah, thank you, Mr. Chair. I think this is a really important question as well. When we did the last expansion, we did not have anyone from a rural area that qualified in terms of the federal requirements. And there's nothing I can do about the federal requirements in order to draw that match down from the federal government. So we were not able to, I'm not sure that anyone applied, actually. I think we had letters of interest, but I don't think that we had somebody from a northern area. We do have rural CCBHCs, just not up north. And so we didn't have anyone that was ready. In terms of when we talked about the Rural Health Transformation Project and those pieces, something that we were interested in, something that we talked to folks is especially the 9 core services, specifically 24/7 mobile crisis, but other things as well, veteran services, things like that, are things that a lot of our providers weren't able to do at that time, and so they weren't going to make certification criteria. And so what we really wanted to be able to do is provide technical assistance to make sure people had those services up and running should there be an expansion ever again, that more of those providers would be able to be eligible for certification criteria. And that's something that was very important to us. Also, these are good services to have, right? So if we have more veteran services or we have more 24/7 mobile crisis, that's a wonderful thing to have regardless of if they become a CCBHC. So that's kind of where we put those pieces together. But we would need to actually have that recognized in a budget, as well as to allow an expansion to happen. I do know people are interested at this time, but it's not something, we can certainly dig out those interests and talk to people and see what that would look like if that's something that you're interested in.
Okay. Final question for you. This one may also be for the CMHs as well, but talking about the patient population, I think this is the first time we've seen some patient numbers since a report back when this started here in this presentation. But also a question about patient population, but outcomes, right? You talked about how many people you're serving and things like that, but kind of as we're learning through the RHT process. It's more about talking about outcomes and how you look at that. Now, you mentioned, I think, the national number of how many less ER visits and things like that. My question is, what kind of outcomes are you looking, other than kind of the numbers of people served? But, with RHT and other things, it's like readmissions. Like, are you reducing readmissions? Are you creating savings at ER? Are we tracking those kind of things? But to the patient population, it's always kind of been sold to us, and you've said it a couple times, kind of that missing middle of the crisis care. But you're also describing a comprehensive care here that CCBHCs are doing, and then you have CMHs as well. So with that patient population, are you serving a new patient that is suffering, or is it kind of somebody that's entered the system at the start and is going through the process? I mean, is there duplication of effort on a single patient, or is it a different type of population that's coming in and utilizing these services?
I think that's a great question. What I will say is I think you probably have both, right? And I think probably some of my friends from CMH can probably talk a little bit more to this, but you definitely have individuals that are being served through some services that are available through the specialty behavioral health services, and then are also the services that are available through their CMH, because they're both entities, right? They can't bill both sides for that, right? It depends on what services an individual is getting. So it kind of shows up different in how it's being billed in a budget and things like that. But they're still servicing that one individual. That's a part of their person-centered plan, and all of those pieces. So sometimes, it just kind of depends on the service and the individual. I do think that you have a lot of new people that are accessing these services because they were either in a county where those services weren't available, because we don't have, the services don't necessarily line up everywhere you are in the state. And so that's something that we see, as well as we can certainly break down some data and get that back to you in terms of, I was surprised how many kids were going to CCBHCs for a program that was largely introduced to us as an adult program. But definitely almost, I think it's like 23% of those are youth. So something where, we're really looking at being able to serve that whole family and those pieces as well. So we can get you we are definitely looking at some of our quality metrics, in terms of follow-up visits after an emergency department to make sure that people aren't going back. But some of those more patient-centric pieces, quicker access to services, making sure people are staying in SUD services, that type of thing, that we're not dropping off the plan. And when we do, that we're able to lift people back up and get us back on track, is something that's very important. We can follow up with some additional statistics on that. We have a report that's about to come out from that evaluation that I think you might be interested in as well. I'm not sure if it's quite bundled up and ready to go, but I'll check with our team about a timeline on that for you.
Great, thank you. Yep, we will follow up and look forward to reviewing that information. So thank you for coming up and for your testimony. We appreciate it.
Thank you.
Next up, we have Julia Rupp, CEO of West Michigan Community Mental Health, and Beth Ann Mitis, the Minister of Clinical Services at Kalamazoo CMH. Thank you for being there. That one went a little bit longer in my estimation of timing and control of the committee. So if you can try and limit to a 15-minute presentation, we'll limit our questions, and we'll get Easter Seals up here with enough time to do their presentation as well. So with that, thank you for being here.
That might help. Good morning, and thanks for inviting us. We're very pleased to have this opportunity. I'm going to start off by talking about sort of the big picture, and then my colleague Beth Ann will talk more about some of the data at the local level, kind of bring it home a little bit. I want to say that I represent West Michigan Community Mental Health, which is a CCBHC, one of the original 13 from 2021. We, like Kalamazoo and many others in that original 13, we had SAMHSA grants to kind of give us a head start before we actually became part of the demonstration, and that helped us getting ready. It's a big, heavy lift, and I just want to say to the last questions that you had, many of the, and West Michigan Community Mental Health is a rural clinic. We serve Lake Mason and Oceana counties, probably the furthest north in the state. There is an issue in the rural areas in that one of the things that the director didn't mention is that The criteria that the state has developed is now more aligned with the federal regulations and allows more flexibilities. And so rural clinics back in 2020, 2021, that didn't provide enough flexibility for them to join the demonstration. Those changes now allow them, and that's why there's more interest now in the northern and more rural areas to participate in this. So I do bring the rural perspective, and we have been part of this demonstration from the very beginning. I want to say that we often use the word expansion, and I just want to clarify that when you talk about expansion, we are not adding clinics. We are transforming the existing clinics. It is a transformation of the public behavioral health system. So in most of the state, the CCBHCs are also CMHs that have met the criteria to become a CCBHC. In Wayne, Oakland, and Macomb counties in that metro area, there are a number of private providers, not-for-profits, that are also CCBHCs. So just kind of remember that the public system looks a bit different in the metro area than it does the rest of the state. To answer the question about population, most of us serve as a CMH, about 70% of the people that we serve have been moved over to CCBHC only. It's a fee-for-service model now. It's not part of managed care. And about 30% is the traditional managed care population now, those services for persons with IDD, residential services, et cetera. So that's kind of what the split looks like as a CMH. So this transformation didn't add new clinics or new sites. It took existing sites and expanded the breadth and the quality of services that we provide. As the director already said, it got rid of things, the exclusionary criteria. So when you walk in the door, it doesn't matter who pays the bill, who your insurance company is, where you live, if you're mild to moderate, which, by the way, is, if you're moderate, sometimes you could go into this bucket and sometimes that bucket. It's just what door you walk into. I would also challenge a comment regarding the mental health plans. It is bifurcated, and the mental health plans receive the funding for the mild to moderate. It doesn't mean they're providing service to the mild to moderate. And if you take a look at their networks, it's pretty small. In addition to that, the other thing that CCBHC does is that it provides services in a comprehensive manner. The public system is who provides this intensive crisis array that the director has described already, and we'll talk a bit more about. So we're catching people early. Earlier intervention connects them to services quicker and helps reduce the costs long-term and also the outcomes. It also creates a common expectation or a common benefit. One of the complaints that consumers often have is that when they walk into one CMH, they get one set of services, they walk into a different CMH, it looks quite different. This provides a national standard. And that's why it has strong bipartisan support, because we know that it's a best practice, right? We're not wasting money by providing unneeded services. It has to be evidence-based. And care coordination is a key component. Essentially, a CCBHC must operate as a health home. You're probably familiar with the health home model. So care coordination must be provided. We know that when you coordinate care, you get better outcomes, and you also save money, particularly in the physical health care arena, and we'll talk about that in a minute. And of course, we get the enhanced funding, at least through the demonstration period. And to the point that's been brought up, there's increased accountability. We have federally mandated and state required outcomes, and we actually get bonus payments based on those outcomes. I'm happy to announce that, for example, West Michigan CMH has met all of those quality bonus payment metrics since the beginning of the demonstration. I want to kind of point to a research that was done by CHART. CHART produced this last June, and what they did is they took a look at the services of CCBHCs and the trending of it from 2018 through 2024. And what they used as a comparison group were the CMHs that did not become certified as CCBHCs. And when you take a look at this data, you can see the green line or yellow line represents the CCBHCs increase in the core services. Those 9 bars represent the 9 core services that CCBHCs are required to provide. The brown lines represent what CMHs did during that same period of time. So this is comparing CCBHCs to CMHs that did not become CCBHCs. And the numbers are pretty dramatic, right? They go from 85% increase to peer and family support to, as the director already mentioned, nearly 500% increase in SUD services. SUD services, this makes sort of the most sense, not just because of need. And by the way, we can provide, as a CCBHC, we can directly provide these SUD services, or we can do it through a designated collaborative organization or a contract agreement with the existing SUD providers that are already in the community. So they become an extension of the CCBHC. But historically, CMHs didn't provide, most CMHs did not provide substance use services. That's just because of the history of who CMH is. That was a bifurcated system as well. But under this model, you're supposed to serve anyone that walks in the door. Sometimes it's very difficult to tell. It's often co-occurring, but it's difficult to tell if their primary reason for presenting a substance use disorder or a mental health issue or some other social determinant of need. But historically, CMHs didn't provide those services. Not only are we providing more services, but remember that we're also required to provide a broader breadth, and it has to be evidence-based. As an example, at West Michigan Community Mental Health, in the beginning of we have always provided SUD services. As being a rural provider, we don't have many substance use providers in our 3 counties. So we've always provided outpatient substance use services. With that said, we didn't provide any services for medicated assisted treatment at the beginning of this demonstration period. Now, in our fairly small CCBHC, we have over 160 people that we provide medicated assisted treatment for opiate use disorders. This next slide talks, basically just looks very similar. This is based on claims data. So these are actual Medicaid claims, and they sort of follow the same pattern as the last slide that I just showed you. I just want to make a note that the increase in numbers isn't just because of need. It comes from a number of areas, right? One of the things that we're required to do was improve access. Almost all, last I checked, it was all CCBHCs. Now offer same-day access. So you don't call and make an appointment and come back later. This is particularly how people need help when they say they need help. If you tell them to come back later, they don't. Or the next time we see them is in an inpatient unit or an ED. You have to give them services when they ask for it. That's what we refer to as same-day access, which is one of those evidence-based practices that we've implemented. In addition to that, we expand the population pretty dramatically. When someone walks in the door and asks for help, we don't want to exclude people. That's part of the model, right? Because we know the earlier the intervention, the better the outcome and the less cost. So if someone comes in and says they're mild to moderate, they don't want a referral to go down the street because they happen to have Blue Cross Blue Shield or they happen to live in a different county. We don't want to send them in another door. We have to help them right then and there when they walk in the door. So that's the expanded population. And the expansion of the crisis array brings a lot more folks in the door. The historical, many CMHs had 24/7 crisis, but they only served a limited population. They took a look at individuals that were in psychiatric crisis, probably in need of an inpatient stay. Under this model, a crisis is as the person defines it. If a parent calls up because their kid threw a book at them, that's a crisis, and we respond. If a spouse throws you out in the middle of the night because you're drunk again and they don't want you in your home anymore, that's a crisis. It doesn't matter what the crisis is, we respond to it. And we connect them, and the connection rate to services, as the director already mentioned, is high. So we keep that person engaged. That's why those numbers increase. I can tell you that at my CMH, the lengths of stay are getting shorter and shorter. So it doesn't mean someone has to be in treatment or services forever, right? The earlier the intervention, as long as the intensity meets their need, the better the outcome's going to be, and they don't have to be in services forever. I want to just say that, and then just veterans, the director already mentioned about veterans, but one thing I want to highlight here, because I'm going to talk about money for a minute, is that some of the increased is because we do purposeful outreach to certain populations. Veterans are one of those populations. But if you take a look at that chart data, and you have, we've given you, there's a link here for the full report, and then we gave the executive report. But if you take a look at it, you'll see, for example, that for veteran services, the greatest number of services to vets is in the assessment and access, and then it kind of drops off. The reason that is because when appropriate and when they want to, now they can stay in services with us if that's what they choose, but when they want, we have agreements with the Veterans Administration, and we connect them through Veterans Navigators to those services. So they go back to those clinics, and we help them get the services through those clinics. So we're still connecting them to services even if otherwise they may not have gotten it, because often those clinics are, especially in rural areas, are far from them. So maybe we provide the transportation, or we help them get the appointment in the VA. So when you take a look at this, clearly costs money. For the state of Michigan specifically, it costs a lot of Medicaid dollars along with general fund dollars, and we're all concerned about the big shift from the federal government to the state government regarding Medicaid. With the assistance of our partners, though, it is our plan to continue to look at that return on investment. And one of the things that you haven't asked about yet, though, and one of the things we haven't talked about, is that we save money elsewhere. You can't look within the behavioral health setting alone. Most of the savings, when you do good care coordination in a behavioral health home model or in a CCBHC, come on the physical health care side. We already talked a little bit about the reduction in emergency room use. You'll see in the chart report that we have already demonstrated a reduction in emergency room use for CCBHCs. That saves dollars on the Medicaid side. The outcomes that were measured on, the quality bonus payment outcomes, a lot of them are health outcomes, right? We're helping control people's diabetes. We're helping control people's weight. We're looking at the other factors that cost money. We're saving money on the Medicaid side. So in the future, we really need to look at this in a more holistic way. And Beth Anna's going to talk about it in a bit, but we also know we save a lot of money in other systems, right? Because of our coordination with the justice system and law enforcement, for example. In our crisis departments, it's going to be a lot less expensive for us to respond and take care of somebody rather than law enforcement or rather than the inpatient unit. I just want to share, before I turn it over to Beth Ann.
Yeah, we are running on some time constraints, so if you
Okay.
can have
We're
your
wrapping
partner
up.
come and give the Kalamazoo update, that would be appreciated.
Just one brief report. This is from the state of New York, and it shows that the state would be cost neutral for that state to invest based on the savings in the emergency room and inpatient unit with the same FMAT rate, and they would actually have cost savings just based on those two factors if they had the enhanced rate. So I'm going to turn it over to Beth Ann now to talk about some specific data.
All right, I'm going to be quick. I'm not going to promise you I'm following every slide. So what I want to talk about is what the CCBHC has meant to Kalamazoo County and other communities that have a community mental health that's become a CCBHC. So when you look at it, we've been able to implement more intensive and more intentional crisis services that happen earlier on in the intervention phase. So when I look at it and I look at the fact that we started implementing a behavioral health urgent care access center, and that was one of the first things we did when we became a CCBHC through the demonstration, is really getting that urgent care access center up. And since 23 when it opened to 25, we've had an increase in those we've served of 1,729 individuals. You can see the breakdown there. What I didn't give you, and I apologize that I could give you, is what's the breakdown between Medicaid and non-Medicaid. I can provide that for you. One thing I want to say about the non-Medicaid is it's not just people without insurance. One of the things the CCBHC really required of us is we had to become better at billing. We had to be more responsible for when we had people entering our service door and we had the opportunity to bill another commercial insurance. We had that obligation to do that. So when we talk about non-Medicaid, it's not just someone who doesn't have any insurance. It's encompassing all of that. So some of the other things that I want to talk about is our crisis services. And when I think about our crisis services, we just implemented in the last really 4 quarters our mobile crisis response team, which goes out to the community for anybody. We always had it for children, but we had to expand that for anyone. So just some of the quick numbers that I'm looking at is that we have dispatched out in the 3 quarters that we have started this 650 times out into the community. Some of that is a duplication of, could be the same family calling us out twice or the same individual, or even law enforcement calling us out for our dispatch. We go out, we meet people where they are, and we help them through that crisis. Typically in the past, they would have went to emergency departments, or they would have called 911 and expected law enforcement to do that. So when you look at that, I'm not going to read these, but I think they're very important. In the PowerPoint, we actually have individuals' responses that received that service and what that service meant to them, and getting that service up front helped them so they didn't have to go further into services, and they were able to maintain their independence and get through that mental health crisis. The other area that I want to talk about, which when you guys talk about where's the savings at, it's really hard because we are implementing systems now that are coming across other systems. So one of the other things between Muskegon, which is West Michigan Community Mental Health and is a CCBHC, they have individuals now that are dedicated to work in the county jail to divert individuals as best they can. In Muskegon, they have 3 master level clinicians that are embedded in their law enforcement departments. They have also implemented what's called crisis intensive training for law enforcement, so knowing how to interact with someone that they're coming upon that might be experiencing a mental health crisis. They also went so far in that county to implement an actual electronic referral system so that law enforcement could make referrals to them when it was a behavioral health need, and that they could know that there's going to be follow-up care. And in fiscal year 25, they had 3,000 referrals come in from that system. Kalamazoo County, I have a slide that speaks to what we're doing with our law enforcement and jail, and we're implementing a lot of those same things. And what I want to talk about is our data in Kalamazoo, is our law enforcement were able to refer 4,000 calls to us. We have law enforcement that are identifying calls that come in, and they have a code that they can put on there as behavioral health need. Then we follow up with them. The law enforcement is able to back out and know that we're going to follow up with them. They've called and we've directly responded 1,343 times with our co-responder, person who's embedded right with the law enforcement, and we've been able to have 354 pre-booking diversions. So when you think about what's the savings, I have to figure out now, how do I get into another system in our state to figure out if I have less people going into the jail, or I'm able to save law enforcement time because I'm diverting 911 calls to our 988 mobile crisis response team. Where do you see some of that savings? And so we're going to have to work with our local law enforcement to figure out how we collect that data and how do we look at that. So I think that those are really important factors, and they all, when you look at that early intervention, it does decrease the amount that people are going to go to an emergency department. The 911 calls going to a behavioral health mobile crisis response reduces the 911 calls. So what we have to figure out as a system is how do we get that data? Because some of that data is from our Medicaid health plans. They're the ones that typically look at some of the costs for the ED and what's happening in the emergency departments. And so we have to work on how to better do that. So when I think of next steps for the CCBHC and what, I'm grateful for being here. I love the CCBHC. It's really helped break down barriers and who can access the care they need independent of their insurance, is that we really want to make it permanent in the state of Michigan. So many kids I've seen that would get services, and then when they become an adult, they didn't quite meet the criteria for the severe, chronic, and persistent, so they would fall through that crack. We don't have to have them fall through the cracks anymore. We can serve them. We can provide that care continuously that they need, and then help them to be independent quicker. Because when we have someone fall through the crack, we know they're going to show up in the crisis sense. So we really want to partner together to figure out how we can do this better up front, so we can lower the cost of Medicaid at the higher end of services.
Great, thank you. Committee members? Representative Roth?
Green.
Oh, Green. Looking alike today. or something.
That's scary that he's looking so good. Thank you. Question for you, as you've talked about the substance abuse and so on and so forth, and this also goes for the director. It seems that Michigan is consistently making it easier and easier and easier to get to these substances. Whether we're changing alcohol or we're changing marijuana, so on and so forth. What categories are you seeing the increase in substance abuse? Is it alcohol? Is it opioids? Is it marijuana? I'm assuming the opioids is dropping as we're making it more difficult to get to it, but I'm also assuming that, I have my assumptions. We'll just leave it at that. What specific areas, as we as legislators are making policy, are you seeing is costing the state hundreds of millions of dollars in substance abuse?
Well, for us in Kalamazoo County, I think it's really dependent and it changes. Like we would say we were seeing a lot of opioid use, and we've had a lot of focus on the opioid use, and that's reducing. So sometimes you see the use of meth increase in certain areas, and it seems to bounce. And I can't be one county that speaks on it, because I don't think it's the same when you go into another rural county, when you think about, what is alcohol more predominant, or is it still the opioids? So it really is based on each county. I think the quicker they can get into care, like the less barriers they have. So like having someone walk through our urgent care door now and say, I need to engage in treatment now, and we can start that right away, is going to be the best thing that will deter some of that rapid growth in any of those.
I appreciate treating the fruit
Right.
of the problem.
You want to get rid of the drug.
I want to get rid of I don't want them walking in your door, because, I think 2018 was an absolute disaster for our substance abuse.
Yeah.
And we're going to start feeling the effects of it in our children's population as they have. It's not alcohol. It's not fetal alcohol syndrome. It's fetal marijuana syndrome.
Yeah, I'll just add another new population that we're dealing with, and that's seniors and marijuana use. A lot of increase in that, and they start to use and they overuse very easily, which causes falls and other kinds of issues. So that's another sort of newer area that we're addressing.
I think it is really trying to expand knowledge to the kids too, and the prevention services, the more you can get some of that out there. But there's not a lot of youth that come through our doors that say, I'm struggling with alcoholism, but we know they're using.
Just one quick, question until we can move to the next presentation. Just as CMHs have created the CCBHCs or become CCBHCs, I guess I'm still trying to process that, if whether you kind of became a CCBHC, did you hire different staff? How much increase of staff was created, or was it kind of a continuation of the work the CMH was doing?
It was a combination of both for Kalamazoo.
Across the board.
We are still a community mental health organization that is a CCBHC clinic. Yes, we hired probably an additional, through our SAMHSA grants and gradually increasing services. I would say as a community mental health organization, we probably hired an additional 100 staff, with probably 90% of them really being clinical staff, increasing our outpatient care, psychiatric care, those services. And then what we had an obligation to do because of the CCBHC is we had to be better with our data collection and how we use data and how we use data to inform us. And so we added like data analytics to some of that, and our financing. Like I said, we had to be wise with the fact that we had to bill other insurances, and we had to be good at it. So we did add to our billing and, eligibility department in regards to looking at that.
With that mild to moderate population, we added new interventions and interventionists, so doing a lot more brief interventions. In addition to that, the last 2 years we've collected that data on new staff. We can forward it when it's ready. We don't quite have it ready yet. But in the highest percentage of increase in staff type, besides the ones that were already talked about, were peer support workers, community health workers, and people with substance use credentials.
I'm sure we're going to have some follow-up questions, but we do need to be respectful of everyone's time. So thank you for coming out here and giving a presentation. Next, we have Brent Worth, President and CEO of Easter Seals. And we have Juliana Harper as well, the Vice President of Programs, Behavioral Health, Easter Seals, and Jimmy Johnson. Thank you for being here. We got about 15 minutes like the last group. Appreciate your thoroughness and brevity.
So I will be, my part will certainly shorten, and we'll definitely leave some time for Juliana and Jimmy. So behavioral health transformation is absolutely long overdue in Michigan, and CCBHCs are proven it's possible. So I'm here to share what it looks like on the ground and why at least we want to make more, or at least sustain, keep doing it. So Chairman Van Workum, Vice Chair Green, Vice Chair Rogers, and members of the committee, thank you for this opportunity. So again, I'm Brent Worth, President and CEO of Easter Seals Mork. This is Juliana, and this is Jimmy Johnson, who's going to share his personal experience with you all. So I'm going to skip some. Oh, I get to be in charge, don't I? All right. All right. I'm going to keep going. So I did want to say something here. I was going to say a little bit more, but what makes us relevant in this conversation about CCBHCs and the importance, we're one of the few non-CMHSP CCBHCs in here in Michigan. We serve over 26,000 Michiganders each year. And so it's one of those things that, are you changing it?
No, go.
Did I change it?
I don't know, go ahead.
All right. So we're serving over 26,000 children, adults, seniors, and their families. We operate across Southeast Michigan, and we provide the full spectrum of care. So that includes both behavioral health, autism, IDD services, mental health, substance use, and crisis care. Again, it's not about our size, but it's really about our experience in operating at the every level in the public mental health system that makes it unique for us. So the breadth of our services, really is something that reflects what the communities need. So being in Southeast Michigan, we've continued to evolve and adapt. In fact, we've been here over 100 years, and through a recent merger combining another 50 years, so 150 years. And so what's really important is the evolution of our services and what we're able to provide. So we're able to meet people where they're at. We're able to meet them in schools, in the communities, wherever, across every life stage. And so before we get into the data, from everything else, so I just wanted to reference a chart up here. And what's really important to this is that every one of these individuals is Michigan residents. So it's not a data, it's not a statistics. These are people who come to us sometimes in their most difficult time and their hardest moments. And everything about what we're going to share on the rest of the day is about service to people like them. So we were part of the initial CCBHC grant. Our journey along with West Michigan started at the same time, 2016. And today we are operating CCBHCs in both Oakland and Macomb County. And we're one of only a few non-CMHSP CCBHCs in the state. And why I bring that up, that distinction matters, because it's not because it's what sets us apart, but because it proves something important, that the model is not dependent on a legacy system. So when we're looking at transformation, we're looking about evolution, it's not built upon a legacy system, it's built on the model itself. And as a non-CCBHC, we bring the ability to forge unique public-private partnerships, leverage diverse funding, and pilot innovative care models that fills the system. We're not outside the public mental health system. In fact, we are part of it. We're just an additional additive. And so since this demonstration project, what we've seen is true systems transformation. CCBHCs have changed how care is delivered, how it's funded, how outcomes are measured, and who gets access. And so the real driver, and what you're about to see possible, is about from the real driver is the payment, the PPS rate. And that's really the engine that drives the success. So it really covers that full cost of care. So it's not just a fee-for-service that we're used to, but the real cost of delivering comprehensive coordinated behavioral health care. That means we can invest in our people. So competitive salaries, training, retention, You know, it means we can invest in technology. So for example, just 2 months ago, we outrolled an innovative patient engagement model called MEND. In just 2 months, our no-show rates dropped from 16 to 9%. In a traditional fee-for-service model, we would not have the funds to invest into being able to provide this type of engagement in this platform for our individuals. So it means we can really invest in the communities than just trying to figure out how to cover overhead. And critically, you know, the PPS rate, it eliminates the wide regional variances that currently exist. And so regardless of where you live in the state of Michigan, you should get the same quality of care, and the PPS makes that happen. So I am going to turn it over to Juliana right now.
Thank you. So over the last several years, being a CCBHC, we've really transformed our infrastructure and how we deliver behavioral health services, and the result is really quite simple. More people are getting care sooner with fewer barriers, and we're actually using our resources smarter and driving whole person treatment options to individuals who need them at the time that when it's available for them. So last year alone, across 2 of our CCBHC sites in Macomb and Oakland, we served 14,674 individuals. We've seen a 97% growth since we started our journey as a CCBHC, with the largest concentration of youth and children. And that frankly just kind of reflected in the partners that we built, plus the demand in the community at the time. So we've been able to serve more people because we're focused on practical, measurable improvements that are solutions that reduce barriers and move people into care faster. Early on, we implemented a client relationship management system, CRM, that really strengthened our front door and improved our customer service. We were able to reduce call abandonment rates from 45% down to 3%. We launched same-day access, both in person and virtually, across 6 locations. People can walk in or schedule within a set block of time for an intake. And on our busiest days, we probably see 65 individuals across 2 regions with an average wait time of 20 minutes for an in-person visit or 12 minutes virtually. So from this perspective, like when we started as early on as a CCBHC, we were maybe averaging 200, 250 individuals at, a month. Now we're upwards of 400 to 500 per month that are coming through, receiving intakes through our locations. So another key success is really around those collaborative partnerships. We invested in outreach models. CCBHCs are designed to coordinate care across systems, and so that could be with medical facilities, doctor's offices, hospitals, schools, shelters. But what we have more than 30 collaborative agreements with community partners across our region. But the point was, like, we really target around some very specific partners. And I'm gonna highlight homeless shelters because I think what people who experience homelessness are the most transient. They're the hardest to get in the care, and there's a really large cost spend because they go to ER visits often. They're not engaged in traditional outpatient models. We, today, we've had 66 intakes just this, outreach and intakes just this calendar year so far. That includes doing those, we have clinicians and outreach coordinators that go into shelters and do street outreach with community housing partners. Last year we did 175 individuals, and we're able to get 125 of those folks into care. So these, the staff they engage, they go into these settings, they have conversations, they're there when they are. It's intended to not be a 4-wall model. That's what's the beauty about a CCBHC. And, and this is what the model really focuses on and makes possible, real engagement, timely access to care, and clearer pathways for some of the hardest to reach and most marginalized members of our community. So just this year, we opened a behavioral health urgent care. We actually opened 2, one in southern Macomb, one in southern Oakland County. This creates another access point to divert ED visits and unnecessary hospitalizations. We serve anyone from school-age youth to older adults. They're experiencing a non-life-threatening self-identified crisis. We will coordinate, do warm
handoffs with crisis hubs, and/or back to their treatment providers, and/or engage them into our intake departments. As I mentioned earlier, children and youth have been our largest area of growth, and the biggest reason is because we've had a strategic partnerships built with schools, using school data and identified needs. Over the years, we've actually served 3,000 youth, more than 3,000 youth, within our school models. This means that we have, in our co-location partnerships, we have currently 17 school districts. We're in 33 schools, spanning elementary through high school. Our therapists have offices in those, and we treat mostly anxiety, depression, trauma, help kids build coping skills, work with the school counselors and the school personnel. And if they need something higher level care, we also provide that in our continuum as that intensive family-based treatment. And we'll connect them to that care. Another key partnership that I wanted to highlight real quickly is our justice programs, where coordination directly supports both recovery and public safety. We have a juvenile justice program in Oakland, and we have a very large adult criminal justice program in Pontiac. Right now, we're serving approximately 480 individuals who are on probation or parole. We also have a referral pathway for prisoner reentry program. This past 2 years, we've been partnering with the 6th District Treatment Court, and we case conference with 3 judges 6 times a month, coordinating care for 62 individuals. Many of the people we support coming out of the justice system, and they need ongoing treatment, substance abuse treatment, intensive treatment for their illness, addictions, and they also need rehabilitative services. They need employment. They need life skills. This model allows for that to happen seamlessly, and the coordination, the relationships we build with judges, officers, individuals themselves help stabilize individuals, and they stay engaged in treatment. They build new routines that support long-term recovery. The last slide I have to talk about is really about those quality clinic and state measures, and some of them connect to our quality bonus payments. We have far exceeded the benchmark on many of these, and that strength really comes in through us transforming our practice models, using data to drive service change, and one that we're really proud of is around suicide risk assessment. We implemented a nationally known zero suicide model, and we consistently have been over 97% in the 97th percentile for assessment of suicide risk. The other thing that I'd like to mention, and this was mentioned earlier, is that that timeliness to service. We are in the top 25th percentile in the state for CCBHCs. We get people in very rapidly, and we get them to stay engaged. We're also not to point of referral to intake, but also from that intake appointment to their next visit. They're engaged in treatment, and it's done very rapidly. With the numbers that we serve annually, that's pretty remarkable, and we would not have done this before without this model. So we highlighted some of our greatest strengths, and we've implemented those practices, and they result in real outcomes for people, holistic outcomes. And with that, I'd like to turn it over to Jimmy and have him share his story on the impact that he's had.
How y'all doing today? I've been receiving services from Eastern Shores Morgue since 2020. I'm diagnosed with schizophrenia. Before receiving services from Eastern Shores Morgue, I was hearing voices, hallucinating. It was a really bad time for me. I was in the streets, barefooted, walking miles and miles with no destination, so kind of confusing time for me at that time. I was in and out of the hospitals for about a year. But now I don't hear any voices or have any hallucinations. The medications that my doctors at Eastern Shores Morgue has prescribed me has worked miracles. I have a psychiatrist and a case manager at Eastern Shores Morgue. I also received my injection from them, from the nurses at Eastern Shores Morgue. And through Eastern Shores Morgue, my case manager pointed me in the directions of Dreams Unlimited Clubhouse. Some of the benefits of attending the clubhouse is the work order day at Dreams, it gave me the opportunity to be a productive member of society again. And the members are welcoming. The environment gave me the courage to go back to school. 2 summers ago, I attended Oakland Community College, where I took 3 classes and almost a hold of a general studies degree. I also worked for East Seals Mork in a T position for 11 months, and that's kind of my story for the impact that Easter Seals has had upon me. Thank you.
Thanks, Jimmy. So Jimmy's story is Jimmy's unique story, but it's not unique to many others in Michigan. So hundreds of thousands of Michiganders either have a similar story or are waiting to share their own story or waiting to write one themselves. So when you think about what's at stake with the continued sustaining of the funding of CCBHC, these are services that are what is at stake. And to us and to many people that are part of the CCBHCs is what does a proven fiscally responsible behavioral health solution look like? And it looks like this. And Jimmy is sharing his own personal experience, but again, it's hundreds of thousands that we can share. So the Michigan again has long awaited for system transformation. And so people that have behavioral health needs have waited a long time, and they really deserve to see this level of commitment carrying through. So the state, the federal government have all invested lots of dollars, and the model is proven to work. It has shown reduced overall cost, overall spend, and it really provides a healthier Michigan population. So, we saw in the other statistics where it lowers inpatient, it lowers the emergency visits, et cetera. This is not a spending increase. And so, you hear about it's an additional spot in the budget. It's not a spending increase. It's actually a smarter use of dollars that are already in the system. So we're asking 2 things of this committee. First, sustain what is already working. Protect what is working. Second is sustain and strengthen the network. So ensure that, high-performing providers, so we're all held to high expectations. They're consistent. They're nationalized. Allow us to continue to do what we do and expand, not even expand it, the expansion's there. Just really look to see how we can do this throughout Michigan. So investing in CCBHCs is investing in a healthier Michigan. So thank you for your time, and thank you for your the opportunity to present today.
Thank you. We appreciate you guys coming. Jimmy, thank you for sharing your story with us. We are running out of time, and I hear a group out the door. But quick question. Mine was going to be kind of like a coordination of quick care question of how do you work with a CMH because you are independent CCBHC. Is there information sharing with a CMH about patients? Is there some coordination of care, or because it's a CCBHC, it's pretty comprehensive in-house with Easter Seals?
So, we've always been part of the public mental health system. So, and really in that metro region, when you look at us, we really, depending on if it's Oakland, Macomb, or Wayne, some really acted like a PIHP and, outsourced all the CMHSP services. We really grew as a CMHSP provider. So all of our systems do coordinate with OCHN. We're building that same technology and HIE in Macomb as well. So long-time care coordination services, we can coordinate through every benefit. So the CCBHC, allows us to really provide services to anybody where they're at. We were already diversified in our revenue and funding serving commercial insurance. This has only enhanced that ability due to the access from that. I don't know if there's anything else that you would add to that.
If there are many individuals we serve right now that get a core CCBHC service, but they also get something that's, from the CMH system that's not covered under the CCBHC model. So we coordinate currently across many domains.
All right.
Work super closely. HIE is there. Information is shared. No duplicate services are offered.
I'll follow up if I have any questions, but thank you again. Thank you, committee members. I think I'm 1 minute late. No, I'm still on time. No need to excuse absent members, so no further business. Meeting is adjourned.